Anil, start. Okay.
Yeah,
Bernard sir, if you permit.
Go ahead. Go ahead. Yeah, time to.
I welcome you all. So our first speaker will be the Professor Asim Kataria from SS Medical College, Jaipur. And he'll speak on CV junction injuries, biomechanics, imaging insight, and treatment strategies. Sir, please start sharing your screen, sir.
Okay. I request all the panelists, to take over. Professor Varnan, Professor Deepak Jha, and Professor Adesh Srivastav.
Yeah, thank you, sir.
Please introduce and ask Dr. Rashim Kataria to present his topic. Please.
Yes, Dr. Asim, start. Please.
Yeah, thank you. Thank you, sir.
Thank you.
So thank you so much, NTSI, for giving me, Dr. Deepak Singh, for giving me this opportunity. So CV junction it refers to the occipital bone around the foramen magnum, including the condyles, the atlas, and the axis. So CV junction as a single mobile unit with atlas acting as a washer between cervical spine and the occiput. It is the most mobile segment within the whole spine, and it is responsible for majority of the axial rotation, extension, flexion of the spine. This is very important. The OC1 joint, the bony structures are responsible for stability and motion, but at the C1, C2 joint, the ligamentous structures, they provide greater stability and motion as compared to the bones. So CVJ accounts for 25% of the flexion and extension and 50% of the axial rotation of the cervical spine. It is a very tough construct and requires very strong forces to result in injury. So it must be suspected in high velocity road traffic accidents, elderly with fall and diving accidents. So coming on to the ligaments can be external or internal. So there are so many ligaments, but out of all these ligaments, the three very important ligaments are the tectorial membrane, the transverse ligament, also called as the cruciform ligament, and the LR ligament. So we'll talk about these. So if you can see my cursor, this is the cruciform ligament. The horizontal part is known as the transverse ligament. The vertical part is there, which joins the basic occiput with the C2 vertebra. And the transverse ligament, it makes the odontode lie in close approximation with the atlas. So this is the cut end of the tectorial membrane, which is also a very rigid structure. And these are two LR ligaments, which are very important and tough structures in maintaining the stability of the CV junction. So this we have discussed. Coming on to some of the important facts about true transverse ligament. In the cruciform ligament, the horizontal part is called as the true transverse ligament. It is a strong horizontal portion of the cruciform ligament. It maintains the position of the dents in sagittal and craniocaudal directions. It articulates with the odontode facet, and it is inserted laterally into the bony prominences on the inner aspect of the lateral mass of the C1. It measures 8 mm in height and 2 to 3 mm in thickness. LR ligaments are very strong ligament. They are 6 to 8 mm in thickness, and they attach dense tip to the lateral part of the foramen of magnum. Apical ligament are not very important ligaments. Some of the studies they consider as vestigial ligaments. So these are the major movements which occur at the CV junction: rotation, flexion, extension, then some of the sliding and lateral flexion. So the intervertebral disc is absent between the C1, C2 joint, and the subocciput C1 joint. It is a ball and socket joint. It is a stable joint. It is a rigid joint when it comes to axial rotation and lateral bending, and it allows more flexion and extension than any other cervical spine joint. So the major movement occurring at occiput C1 joint is the flexion and extension, which is also called as the yes movement. And the C1, C2 joint, it has a flat surfaces or biconvex articular surfaces. It allows gliding of C1, and it allows wide rotation of C1 around the dents, like around 25 to 30 degrees. And it also permits flexion and extension to 10 to 22 degrees. So the flexion and extension, the joint involved are occipito-atlantal and atlanto-axial joint. These are the degrees of the movement which these joints offer. And what limits the flexion? This is very important. What limits the flexion? Flexion is limited by the tectorial membrane and the contact of dens with the basion. This is limited by the flexion is limited by this, the contact of dens and basion. Similarly, the extension is limited by the tectorial membrane, stretch of the tectorial membrane, and the opistheon to posterior arch of the atlas contact. So it doesn't allow further extension to happen. So this is how the things work. Coming on to the rotation, the joint responsible for rotation mainly is the C1, C2 joint. The maximum range of motion is 37 to 42 degrees, and over rotation causes facet joint interlocking. So any rotation beyond beyond 40 degrees, 35 degrees would lead to angulation of the contralateral vertebral artery. And if the things are not checked in road traffic accidents or any other injuries, if the rotation goes more than 45 degrees, the ipsilateral vertebral artery occlusion can occur. So this is how the ipsilateral vertebral artery is affected at a bigger range of rotation, and the contralateral vertebral artery, it is affected at a even relatively smaller range of rotation. So the anterior posterior translocation between the dens and the anterior ring of atlas, in adults it is up to 3 mm. In young children less than 8 years of age, it is 5 mm. So if the ADI is 5 up to 5, the rupture of crucius or transverse ligament is suspected. And if it is more than 5, the rupture of both the transverse ligament as well as LR ligament should be suspected. So failure of one LR ligament results in moderate rotatory atlantoaxial instability. Bilateral failure of LR ligament causes craniovertebral instability. So whenever we find the condylar flexures are bilateral, so it is otherwise like it is almost certain that this patient has got a CVJ instability. Transverse component of cruciate ligament is very strong and thickest part of the entire spine. So it is a predominant stabilizer of the C1 around the dens. Transverse ligament injury or any ligament per se is incapable of repair by itself. Transverse ligament injury renders C1 unstable and mandates C1 C2 fusion. So coming on to the this lateral bending, the occipital condyles, they restrict the lateral bending of the OA junction to 3.4 to 5.5 degrees. The atlantoaxial joint, they can reach up to like 6.7 degrees of lateral bending. So this is how it works. So in a very interesting study by Oshima T and Konda T et al., so they studied pathological observation on fatal injuries to the brainstem and upper cervical cord in traffic accidents. So out of around 150 patients, so pedestrians were the most common victims, followed by the drivers. The pontomedullary junction was most commonly injured site. Skull base fracture with or without dislocation of the upper cervical joints was seen in 146 out of 149 patients, like dead patients. And hyperextension of the neck was there without any like any fracture in just 3 of the cases only. So out of 149, only 3 patients did not had the skull base fracture or dislocation. They had just hyperextension of the neck. Intraventricular hemorrhage was a common feature when it is associated with brainstem and upper cervical cord injury. Basilar artery tear was found in 17 of the cases. ICA tear was found in 20 of the cases. Interestingly, blood alcohol concentration over like 0.5 mg per ml was seen in 40 of the patients. So this was very interesting study. I wanted to share it with you. Occipitocervical dislocation at CV junction is leading cause of the death in road traffic accidents. There can be flexion, distraction injuries. Pathological flexion increases tension on the cruciate ligament or the odontoid waist. Tectorial membrane, as we know, it is the continuation of PLL cranially, and it is attached to the basion, and then further it is attached to the durameter. So whenever there is a great stretch on the tectorial membrane, it can lead to dural injury. Hyperextension injury leads to the fracture of atlas as the posterior ring, fracture of the axis at the pars interarticularis, and fracture of odontoid. Supraphysiological rotation can lead to LR ligament injury, which is very difficult to diagnose on the MRI. The transverse ligament injury you can still diagnose on the MRI, but LR ligament injury is very difficult to diagnose. Compression and axial loading, they cause burst fracture of the atlas and occipital condyles. So a brief about the imaging insights of the CV junction. Diagnosis of a CV like craniocervical disruption is often missed on the plain X-rays. Occipito-atlantal dislocation on lateral C-spine X-rays. As per the ATLS protocol, it is there. So one has to see for the prevertebral soft tissue swelling. Powers ratio, it is like only good for anterior dislocation, not good for posterior and type 2 dislocations. Rule of Spence and rule of Harris of 12, rule of 12 which is called, it holds good for all type of atlanto-occipital dislocation. So it is a better like in terms of getting the information about the atlanto-occipital dislocation. So CT cervical spine, including the foramen magnum, as well as reformatted views, including the sagittal and the coronal views, they increase the detection of odontoid type 1 fractures and occipital condyle fractures, which are otherwise missed on the cervical spine radiographs. So any suspicion of craniocervical disruption, an MRI is warranted, and as it picks up ligamentous injuries, intramedullary changes, hematoma formation, and epidural and prevertebral space. So if we are suspecting a vascular injury, a CTA or a MRA is advised. So catastrophic secondary neurological deterioration can occur if there is delay in the diagnosis of unstable CV junction. Pediatric age group is 2.5-fold higher risk of incurring CV junction dissociation from deceleration injuries than adults. This is because of higher ligamentous laxity they have and proportionately larger head size and less inclined lateral masses. So what are the guidelines? Guidelines are CT scan of the cervical spine, as I have already told in the reformatted this thing, and with the coronal and sagittal reconstruction, or MRI within 72 hours of the injury are there. So atlantodental interval is very important interval. So it is of 3 types: anterior, lateral, and posterior. Because of the time constraint, I would not go in the detail. So this is how one has to know about the lateral. This is the lateral ADI. All of us, we know the anterior ADI. This is the anterior ADI. This is the posterior ADI, and this is the lateral ADI. All 3 ADIs should be seen properly. So the good thing about posterior ADI is it is a direct reflection or direct measurement of the space available for the cord to traverse. So this is the beauty of posterior. So this is how one look for the rule of Spence, which is like more than 6.9 we know. Posterior ADI we have covered. So MRI is choice when it is an established disruption of the craniocervical region. CT scan to rule out the injuries of the vessel. So I would not like to go in these craniometric lines because of the time constraints. This is the Chamberlain's line we should know. This is the McGregor line, McRae's line, then Clivus canal angle. These are very like helpful in the diagnosis of this thing and in the follow-up when you treat the patient. So you should be like following the patient on these variables. Rule of Harris is very important in the diagnosis of atlanto-occipital dislocation. Maybe it is anterior, posterior, or type 2 type. So powers ratio is also helpful. I would just skip them in the interest of time. Coming on briefly on the treatment strategies. So temporary stabilization is very important. Immobilization with the neck collar and skeletal traction. So in some of the cases, the traction is contraindicated, like in type 2 atlanto-occipital dislocation. The traction is contraindicated because the C0, C1 is already like distracted. So halo waist is a good option, especially in the children. So orthosis for CV junction, the mobilization is done for at least 8 to 12 weeks. So these are different type of the halo orthosis available, and these are the different percentage of flexion and extension, lateral bending and rotation they restrict. So the best among all the halos are the halo, the orthoses are the halo which restricts the flexion and extension by up to 96%, lateral bending to 92 to 96%, and rotation to 98 to 100%. So these I would skip in the interval. This is a collar which looks like the Philadelphia collar was. This was developed by our Department of Rehabilitation at SMS Medical College, and we are using it like. So when to go in for surgery? When there are multiple fractures, first indication. When there is instability. When there is chances of mal or non-union due to vascular insufficiency, or when the cord is compressed and it is leading to urological deficit. So these are all like available constructs we have. The challenge is orthodesis. The area to be where the orthodesis is to be done, like the facet joint, it is so small that doing orthodesis at such a small place is really a challenging job. So injuries can be ligamentous, bony, or combined. The principle here is the bones unite, but not the ligaments. This is the principle. Whenever we think that the ligaments are gone, the early surgery has to be like taken. Isolated ligament injuries, there are so occipital-atlantal dislocation where LR ligament or tectorial membrane is gone, transverse ligament injuries, and rotatory C1, C2 dislocation. So these ligaments, when we think are gone, early surgery is indicated. So I would not go in detail of this. So this is posterior dislocation. This is posterior dislocation. This is distraction. You can see the distance between the occiput and C1 is too big. So it is distraction. Powers ratio, we have already rule of Harris. So management is urgent operative stabilization in case of occipital dislocation. Traction is contraindicated in type 2 occipito-atlantal dislocation because it is already distracted. So the transverse ligament injuries, they result in anterior C1, C2 subluxation and dislocation. This is very important. The C1, C2 dislocation can occur with intact ligament in the presence of a fracture odontoid or os odontoid. This is very important for the young viewers. So the MRI is also a diagnostic modality in knowing the transverse ligament injuries, thin cut CT scan and X-rays. This is the different classification, Dickman classification, where these type 1 injuries are ligamentous injuries. Type 2 injuries are bony injuries. So as principle, when the ligament is torn, early surgery is required. When the bone is fractured, we can wait. So this is how like a normal transverse ligament look like on the MRI. Like there is T2 hyperintensity behind the ligament, T2 hyperintensity in front of the ligament. And this is a hypointense thing in the T2, this thing. So in injuries, you can see the discontinuity is there in the MRI. This is the direct evidence that this is ruptured. This is not the continuity is breached. Okay. So this is the way of doing the things. So this I've already discussed. Management of transverse ligament, early surgery, C1, C2 fixation in type 1. Type 2, a hollow brace trial can be given. So these are C1, C2 rotatory, this thing. These are seen in children. I would not go in details of this. There can be isolated fracture of condyles, then C1, C2 isolated fractures, combined C1, C2 fractures. These are common. Then occipital condyle fractures are important. There are the Anderson and Montesano classification. It divides into 3 types. Type 1 is stable, type 2 is still stable, and type 3 is unstable. So this is how like it look like. So depending on when the ligament is gone or when the bone is fractured, we should go ahead. So this I want to reiterate. Any patient with bilateral occipital condyle fracture should be assumed to have an unstable CV junction unless proved otherwise. This is very important. Coming on to the occipital condyle management, like type 1 fractures are and type 2 are stable, can be managed in halo jacket, and type 3 are unstable, require surgical fixation. Fracture of the atlas. So surprisingly, the isolated fracture of C1 rarely cause neurological deficits, so can be like we can wait. This is the type, this is the atlas fracture Jefferson 1, 2, 3, 4. And then when the Jefferson fracture is associated with transverse ligament injuries, then we might have to go in for a surgery. The most they heal satisfactorily with orthosis. Okay, the rule of Spence to know the integrity of the transverse ligament. So this I will skip in the interest of time. Coming on to the odontoid fractures, they comprise of 8 to 18% of all cervical spine injuries, and they have got two peaks. One is childhood and elderly. Then there are hangman fracture and miscellaneous fracture for the C2. Type 1, type 2, type 3 odontoid fractures we all know of. This is the pars interarticularis fractures of hangman, and there are some other miscellaneous fractures. This is a very important slide I would like to show. So what makes the pars interarticularis very prone to fractures, and what makes the odontoid, the neck of the odontoid, very prone to fractures? Odontoid is the only cancellous structure in the spine which resists forces other than compression. So there are so many forces acting on the odontoid, not only the compression forces. There are like lateral bending, there are pushing and pulling of the odontoid, and the waist of the odontoid gets too much of the pressure, so it is liable to get fracture. Second important thing, why the pars interarticularis is the weakest part of the C2 vertebra, because there are two motion planes. One is this one. There is one facet. The superior facet of C2 is this, and the inferior facet of C2 is this. So you can see the motion planes of the proximal and distal joint. This is the proximal joint. This is the distal joint. They have a sharp angle and have a considerable offset.
That's what
between
total
them.
some 1130 something it came.
So this portion of the bone, this is further weakened by the groove or vertebral artery. So that means this area of the bone is very weak and it is liable to break. So this I need not to this is Anderson-Ollenz classification. We all know this is the Grover modification of type 2 fractures. And we know that when the fractures are like the fracture line is extending anterior superior to posterior inferior, so it is type 2, and when it is extending from anterior inferior to posterior superior, it is type 2C. So the management principle is the amount of displacement and the extent of ligament injury decides how the patient is to be managed. So posterior fixation is done when the fracture is comminuted, when the transverse ligament is breached, and when the line is anterior inferior to posterior superior. And the anterior, like transodontoid lag screw, is done when the transverse ligament is intact and the fracture line is either transfer or anterior superior to posterior inferior. Coming on to the hangman fracture, these are the bilateral spondylolisthesis of axis, traumatic one, and the fracture line passed through the pars interarticularis, and this is the FND's classification of hangman fracture. The principle of management in this is it depends on the angulation and dislocation. So if the angulation is more and if the joints are dislocated, so early surgery is required after reduction. So almost all the hangman fracture, they heal with traction followed by 12 weeks of external cervical immobilization. Significant C2, C3 disruption when it is there, or failure to induce and maintain reduction. When we are not able to maintain the reduction, open reduction is in the form of surgery is required. And so the amount of displacement and extent of ligament injury, it decides what is to be done with these fractures. So these are some figures of our model. I would like to stop here. Thank you so much for a patient hearing, and I would like to answer if there are any questions.
Thank you, sir. Thank you, sir, for
Thank you, sir, for a very wonderful talk. As I do not see any query here,
Okay.
so I would like to
I think
invite comments.
we can ask for questions in the
Yes, sir.
last
Yes,
of
sir.
the talks. Okay. That will be good. And if we have control over the other audios, we
Yes,
can
there is
mute,
some
or
of
if
the audio which is still on during the presentation.
so it
Please
is
mute your
no.
audio
If the
when the presenter is presenting.
No,
Dr.
sir.
Deepak, if we have
Sure,
got the
sir.
control,
I'm looking into
we
it,
can
sir.
mute.
I'll do it.
Okay, thank you.
I'm requesting also everybody, to please place yourself on mute mode when presenters are on. So please.
So Dr. Nupur
Sir,
will be.
yeah, with the chairman's permission, I'll invite Professor Nupur for the next talk about the stabilization of CVJ. Nupur, sir?
Can I share?
Yes, sir.
Good evening, everyone. I sincerely thank the Neurotrauma Society of India for this wonderful opportunity. Dr. Deepak, good friends Anil and Subhash, respected panelists. Am I slide C?
Yes, sir. Yes, sir.
Yes, sir. Since.
So the topic given to me is from stabilization to realignment, surgical paradigms in CV junction trauma.
Nupur, go into slideshow.
Yes, I'm going, sir. Is it visible, the slides?
Yeah,
Yes,
okay.
sir.
Is the
Yes, sir.
slides
Yes,
changing?
fine.
Yeah, changing, sir.
Yes. So, okay. So these are the two typical fractures, what we see at the CV junction. And this is a type 2 odontoid fracture. This is a classical hangman's fracture. We all know from the wonderful presentation by Dr. Ashim just done. It has made my job much easier now. But I'm not going to talk about these two fractures here. My talk is going to focus on another type of fracture. And I decide because it's difficult to give justice to all the fractures in the limited time given. So I'm going to focus on something which is categorized. We've seen Dr. Hashim's slides also. Some people call them miscellaneous fractures. Some people call them type 3 fractures. But I prefer this term atypical hangman's fractures. And let me tell you, they're not rare. They're quite common fractures. So what exactly are we talking about? We are talking about this kind of fractures. Now, I was taught in my residency itself that whenever there's a ring, for example, there's a bangle, glass bangle, if it breaks, it will always break in two places. So we know the classical hangman's fracture. As you saw here, it always breaks in two places here, the ring. And so similarly, just imagine that the ring, instead of breaking at the parts, has broken through the body. So that is why I told you I prefer the term for these fractures rather than terming them as type 3 fractures or miscellaneous fractures. I prefer the term atypical hangman's fractures. Now, this is a young male who presented to us in acute presentation. He, like many of these patients, they do not have deficits for the simple reason that there is a wide canal available at the CV junction. These are the SAG images. Now, this is a very dangerous bony fragment here. The same fragment is seen in axial images here. This is the analysis, and this is we did the fusion. And on one side, we got the screw through the fracture, which we tried to do. That's what I did try, but as you can see, it is slightly malpositioned. We, in fact, in this patient was done many years back. We did a C1 to C4 fusion, and there was one side screw malposition, but did not result in any significant neurological injury. So we continued, we persisted with that. When we saw this patient, we did a C1, C4 because I was not confident that my C2 screws purchase will be good. And that is the reason I went to C1. So I want to bring up this issue here that what levels to be fixed when you go posterior. So for example, in this patient, today, if I operate this patient, I may not go to C1 and I may not go to C4 also. In fact, you see, this is a very good CT scan at follow-up. You see very solid C2-3 fusion has taken place, and very good to see that there is C1 C2 fusion has not taken place. So the question I put to the audience is that can we remove the C1 screws in this patient, especially if he is complaining of significant movement restriction? So this is at follow-up. You can also see that this was the fracture and it has completely fused with our screws at the end of 6 months. Another young female, she also has acute presentation. In addition to the previous fracture, there's also, if you see very carefully, and these words are very important, there's significant comminution in the vertebral body of C2. You can see here, there's an angulation at C2-3. The facet has not only fractured, but displaced downwards. The remaining facet has displaced downward, and I will come back to these points a little later. You see this MRI, as Dr. Rashim showed us very nicely. This is the hyperintensity seen in the transverse ligament. So transverse ligament is also not intact. And this, so we did a C1, C2 fixation in this patient, and we had a good outcome. So you can see the fusion at the end of 3 months. Another young male, but this time this is a delayed presentation. This is 2 years down the line. I'm sorry, this previous patient was a C1 to C3 fixation. So one C1-4, one C1-3, and now you can see that there's significant amount of displacement in the facet joint. And this is one of the messages in the talk is to have to focus on the joints, not only in the congenital type of ADs that we atlantoaxial dislocations and anomalies that we do, but also in fractures, because it is very important. And we will build on this idea more and more as we go. You can see this fracture. You can see a lot of comminution in the joint on the right side, significant displacement. I mean, this joint is not capable of handling the body weight, the head weight. It's very clear. And this is the displacement which we commonly see, but we usually neglect these slides, these views. So we did a C1, C2 fixation, and luckily after 2 months, this everything fell into alignment, and this patient did well. This is the post-op X-ray at 3 months with a C1, C2 fixation. Things are doing well, and patient is also doing well. This is a 3-month X-ray. But now this is another unfortunate patient. This is a typical hangman's fracture, but like many patients in our country, has come to us after 3 months. Now this patient, as if you remember, this was the fragment I was telling you about in the first case itself, and this is a dangerous thing, because if the anterior fragment moves something like this, you see the space available for the canal. This is very, very narrow here. And already this is a 3-month-old injury. With traction, nothing happened. Flexion extension, there's no movement. So with this many years back, we decided, this is the MRI, significant cord compression, as you can see. So we decided to do a transoral surgery in this patient. We did an excellent this decompression. My teacher did this, Professor Chandramoli did this surgery, and we did a very good decompression from the front. And then those days, he was not affording the screw, so we had to go into the wires. We did an occipito to C5 wiring construct now. And so these are the unfortunate patients who come late. And although during the hospital, he did not improve, and we did not have any follow-up on this patient. So this is a very typical group of patients, which are, I would like to use the term atypical hangman's fractures, but miscellaneously people call them miscellaneous fractures. Some people call them type 3 fractures. So we'll go into a little more detail in these fractures. There are 12 cases at that point of time. Age range is obviously they're all young patients. Male to female ratio is quite obvious. Mode of injury, delayed cases were 4. We had good follow-up in 9 patients. 3 patients presented with neurological deficits. So basically 3 out of 12, this means 1/4 of the patients presenting with neurological deficit. This means this is a category to focus on. If you see the fractures, the main fracture alignment was coronal, sagittal, or type 3. Pars involvement, bilateral was 4, but only unilateral and predominantly body involvement in 8 patients. Facet involvement, which is the crux of our presentation today, was seen in 11 out of 12 cases. Foramen transversarium, which usually we dread, was seen in 9, but vertebral artery injury was luckily not seen in any of the patients. AD and transverse ligament injury in 7 patients was intact. C2-3 instability as judged by displacement and angulation were seen in 5 and 4 respectively. Very important, we need to focus on C2-3 discoligamentous complex, which was intact in 7 cases. The ALL-PL integrity at C2-3 level was intact in 4 cases, disturbed at 8 cases. So you can see the variety of surgeries which have been done. So again, that treatment has not been standardized for these fractures, and also gives you an idea that you should have an individual approach for all these kinds of fractures. So we did a C1, C2 fusion for 3 cases, C1 to C3 in 5 cases, C1 to C4 as I showed you in 1 case, a transoral followed by C1 to C3 in 2 cases, and a transoral followed by occipito C5 fusion in 1 case. All these transversal surgeries were done many years back. Screw malposition, as I showed you, we had two, but none of them resulted in any significant neurological deficit. We were able to place the screw across these difficult fracture lines in 5 cases, as you can see here. The follow-up, as I told, was available for good 9 patients, a mean of nearly 6 months. All patients were neurologically intact. The bony alignment was good and satisfactory. Fusion was achieved in all the 9 cases. Now, this brings us to the discussion of how to manage this patient. What does the literature say? Now, those of you, some of the residents might have recently passed, and if they are aware of this, in the year 2013, 12 years back, there were guidelines published for management of cervical spine trauma. And these kind of fractures were interestingly labeled as more or less benign entities. What means that these, just according to them, the management is simply to put them on collar or maybe a Philadelphia collar or a halo brace. Now we all know how is the compliance with the halo brace. Whereas there is an interesting other group which with these 2 articles and many other articles which say that these so-called atypical hangman's fractures are potentially unstable, as we saw in those 4 cases, and have a higher chance of neurological deterioration. So managing them conservatively, you have to think again. The people, as I show you, there's a group which says that all these should be managed conservatively, as they are diverse and relatively infrequent. These are the articles which support this kind of a view. Whereas the same group, and they did not distinguish between typical and atypical hangman's fractures. We all know the drawbacks of a prolonged halo immobilization. These were not highlighted in these articles. Even they noted that atypical hangman's fractures can be observed in about 50% of cases. They also noted that 8 of 17 patients with sagittal fractures, which were initially managed conservatively, ultimately required atlantoaxial fusion for treatment of chronic neck pain. So in the present cases, we had a total of 15 cases, but out of them, I'm presenting 12 because we had 80% cases which were atypical at that point of time. The most interesting word here is an intra-articular fracture. We all know from our basic knowledge of orthopedics, what does presence of an intra-articular fracture imply? This means that the surgeon has to be very accurate with his reduction, and if you do not reduce these fractures properly, there's a tendency to have a poor functional outcome, especially the neck pain and other things in future. Fracture and collapse of the lateral mass of C2, which is associated with fracture vertebral body, should be considered as indication of operative treatment, because this is the weight bearing area, and I'll come back to this point very soon. So these 3, I really like these statements. So if LH is stable, these hangman fractures can show catastrophic results with primary conservative therapy, and this is one of the factors you need to take into consideration why to focus on this group of fractures. However, these subtle differences have to be studied, and this is one of my conclusions, thoroughly in future research to adapt treatment algorithm and eventual outcome. Accurate fracture reduction and realignment of C2-3 was seldom achieved in the conservative managed treatment of unstable hangman's fracture. All of us, I think, would believe this. So what is the importance of C2 facet? I think C2 facet is a very important but however neglected area in all our assessments of fractures. The upper 2 photographs. Pardon?
No, sir, you continue, sir.
Yes. So upper two photographs are normal, are taken from normal patients, and this is just to highlight how the normal weight bearing occurs at the CV junction. From the occipital condyle, the weight of the entire head is transmitted to the C1 lateral mass, as we know, and Dr. Rashim also told us that there is no C1, C2 disc. So all the weight of the head through the C1 lateral mass directly comes to the facet. So facet is the load bearing area. Even in the coronal, you can see that as if it is the facet is holding the head through the atlas vertebra. So all the weight, please remember, is falling on the C2 facet. Through that, some part of the weight, as we know, goes posteriorly through the inferior facet of C2 to the C2-3 facet joint. And also some part of the weight goes through the C2 body to the C2-3 disc space and then further down the spine. So this mechanics of weight bearing, if we understand that the importance of facet. Now imagine, you can easily see this angle of the fracture fragments. Okay, we can see that this is 100.49, definitely less than what should be normal. you can see here how with the weight of the head, the displaced fragment fracture fragment has come down almost till the C3 level. This shows the importance of this weight bearing axis. We have to reestablish this weight bearing axis. There's another classification. There are very few classifications which have focused on the articular facet. For example, this classification which came very late in 2021 just says if the lines coming onto the facet have to be studied, and they categorize this, but it is not as simple as that. We see much more complex injuries than this. This is the AO classification, widely followed. Again, no significant mention of the facetal involvement, which I think is very, very important, as I showed in the cases. McCormick's classification of load sharing, I don't know how many of you know about this. Those, especially, I think, young surgeons who do a lot of thoracolumbar trauma, I think they may know about this. This classification decides how much a body, for example, a L1 fracture or D12 fracture vertebra, can take the load of the remaining spine. Now, a body can take good load if the load sharing score is less, and it cannot take load more if the load sharing is more. Now, there are three categories. There are three factors which are taken into consideration: the amount of comminution which is involved, how the fragments are displaced, and how much is the deformity, that is the angulation. So, if significant part of the body is comminuted, obviously this body, it cannot bear any weight till this fuses. If the displacement between fracture fragments is very high, we know that natural process of healing is going to take much more time. And the greater the angulation, the greater the movement and small movements, the tendency of the upper body to move forward. And so in this case also, there will be lesser chance of fusion. So what we have done in a unique way is we have tried to apply this classification to the C2 facet. And so preoperative CT scans of all included patients were reviewed. Severity of superior articular facet fracture was studied. And we studied, like this classification, three things were studied: the facet angle, the extent of comminution, and the displacement of fracture fragments on the affected facet. If both the facets were fractured, the score on the more severely affected facet was considered. Each factor was graded from 1 to 3 based on severity. The minimum score that could be obtained was 1, maximum 9. The injury was considered to be severe when the total score was more than 5. So this was the initial, now we have more than 25 cases, but this was the initial analysis of 12 patients, I think, in which most of these were 5 or more than 5, but there were 3 patients which had a score of 4, 4, 3. I mean, looking back, I may have probably conserved them, but we decided to go for surgery in these patients. And I think this is a very good classification system to decide whether even to decide operative versus non-operative. This is what we propose. So to conclude this part of the presentation, atypical Hangman's fraction need to be identified. There's high tendency for neurological deficit in these patients because simply the load-bearing structures are damaged. Decision of making in situ body fracture should take into account the facet integrity because that is the main load-bearing area. Of course, ligaments and disc integrity is also important. Posterior approach is preferred, and definitely further prospective studies are required. Now, quickly, last 4 or 5 slides. There is an old C2 fractures is a problem, especially in our country. Patients come very late. Now, this is a 15-year-old boy. He has fallen maybe almost in last year, and he's almost bedbound now. Now, my question to the audience is: would you do a long segment fixation or a C1 C2 fixation for this patient? And I believe that we should always and only do a C1 C2 fixation. The key to success in these patients is to enter the joint, to break all the adhesions, to break these small adhesions which are formed here. Everything can be done from posteriorly, and then with the instrumentation available to you, get the C1 and this fragment back. Then we can achieve a result like this. I don't think these patients should undergo anything kind of occipito C3, C4 or a long segment fixation. That is not required, provided you know how to enter the joint, release the joint, release all these adhesions which are formed over a period of months, and then only these fractures can be. There's no need to go from occiput to down subaxial spine. This is my message. Food for thought: can some fractures be managed with only unilateral screws? Yes, I think there is a distinct category of such patients which can be managed with only unilateral screws because all they need is some immobilization for some time, and then the fracture will heal. For example, this patient has a slight displacement of the upper segment of the fracture, and despite trying everything, I was not able to get it in perfect alignment. The MRI was also indeterminate whether transverse ligament was intact or not. So I just did only a one side transarticular screw, unilateral transarticular screw, and this fracture over a period of 3 months fused very nicely. So this is something just food for thought. I think there is a distinct category of patients of CV junction trauma which can be managed only with unilateral screws, but we have to decide and we have to study these patients carefully to decide. Thank you. Thank you very much.
Thank you, sir, for a nice presentation. Hello.
Thank you.
Yes, sir. Now, with chairman's permission, we'll proceed to the next presentation by Professor Rajneesh Arora. He will be presenting interesting cases related to CV junction. Sir, go to slide mode. Yeah, your slides are seen, sir.
Very good evening to all of you. Am I audible?
Yes, Mr. Nish,
Yes, audible. Sir.
So thanks to NTSI and Professor Deepak for giving me the opportunity. And after the excellent talks of Professor Ashim Kataria sir and Dr. Nupur Puthi sir, I would be presenting a few collection of cases which are more common than what Professor Puthi showed us. And they are the more common one, which would be the bread and butter of each neurosurgeon in daily life. So my first case was a young male, 26-year-old, who had a head-on collision, a car versus car. He was driving, and he presented to us with intact neurology. There was no deficits ever there, and only problem was his pain in the neck. And on examination, we found that there was some tenderness there, which was in the neck. There was nothing else, and this was a typical hangman's fracture. You can see the fracture line passing through the pars interarticularis. It was complete on the right side, while it was slightly incomplete on the left side. So vertebral angiography is a norm to do in all these cases. So luckily there was no injury to the vertebral artery, and we could see the flow on the superior levels after the fractures, though the fractures were passing through that. So there was angulation of the C2 vertebral body, as well as there was an anterior and inferior chip of the vertebral body, which was there. So for the young residents, to study the angiography and the distal flow of the vertebral artery is important. As the patient was neurologically intact, so there is less chances that the circulation was hampered, but you should still see in each and every case. So this was his preoperative MRI. So you see there was a discal injury also, and the disc was impinging on the cord, though there was no neurological deficit. So this classifies this patient as a Edward type 2 fracture. And I was thinking of putting the question to the audience, but Dr. Nupur Puthi has now given the answer that we should try to avoid C1. So but this was what we did, and from the next time I will also put a thought to this thing that I would like to avoid the C1. But we tried to negotiate the fracture fragments here, and on the right side we were able to go with the pars screw, and the left side we placed a pedicle screw on the thing, and this was his post-op CT. So alignment was restored, and there was so we were able to negotiate through the left side, and the right side we became content with the pars screw only. So the second case, the patient did well. The second case was a neglected fracture, which has happened about 25 years back. And the patient was normal after the injury, but he now presented with pain and numbness in the left upper limb. On examination, his tone power was normal.
One query, sir. The previous patient.
Okay.
I'm Dr. Raju Kadam, sir. I'm a consultant neurosurgeon in Hubli. I had a similar case. I approached anteriorly, did C2, C3 ACDF, sir.
Okay.
Yes, we can, from approaching anteriorly, we can remove that fractured segment, and also whatever the disc is impinging, that we can remove, put a bone graft or P case, and fix C2, C3 anteriorly with the plate. Little difficult, but with a longer neck and giving little more extension, we can do ACDF anteriorly, C2, C3 ACDF.
Dr. Raj, I think this anterior versus posterior approach is a different philosophy, and we'll talk at the end of the talk.
Okay,
about that. Okay. So Rajneesh, please continue. We'll take questions at the end of presentation.
Yes. I will also like to comment that there are multiple ways to belly cat, and we will discuss it later. So this patient was a 56-year-old male, had injury about 25 years ago, and now presented with left-sided upper limb radiculopathy. And on examination, there was bilateral Hoffman which was present. Power tone was normal. Bilateral supinators were inverse, and the lower limb reflexes were exaggerated. The other things, bladder bowel and sensory, all was intact. The planters were mute in this patient. So this patient did have a component of myelopathy along with the radiculopathy. So spine, there was no tenderness, no deformity. So this was his preoperative MRI. So you can see that there was a significant compression on the CV junction. And these are the T2 sequences. You can see that there is some instability there, which has now precipitated as the myeloradiculopathy. And axial of MRI. So this was his dynamic axis. You can see that on the neutral as well as on the flexion views, there was significant movement of the C1 in relation to C2, and on extension, it was getting reduced. So it was a reducible injury. So preoperative CT, I'll just like to share. So there was a significant disalignment there, and so this was the segment which was moving ahead, and as you can see, there was no cortex on the inferior side, so this doesn't qualify for a os odontoideum kind of thing. So preoperative CT. So it was a non-united type 2 odontoid fracture, and with cervicomyelopathy. So we did the posterior instrumented C2 fusion, C1 C2 fusion, and the patient did fine thereafter. So I will not share the CT because there was no malpositioning of the screws, and the good alignment was achieved in this patient. So third was a young lad who was a state level athlete, and while performing judo, he had a backflip, and his occiput hit the ground. He presented to us in a very bad shape. There was asymmetrical quadriparesis with left-sided injury more severe than the right. The left upper limb power was 0. Lower limb was again 1 to 2 by 5. Right side proximal power was 3, and distal upper limb was 1 by 5. And lower limb was slightly better, 4 by 5 in proximal and 3 by 5 to 2 by 5 in the distal segments. And there was a graded sensory loss, and which was again more on the left side. Bladder bubble control was lost. Fortunately, his respiration was okay when he came to us. So there was loss of reflexes on the other side, and perianal sensations were also lost on the left side. So the spine examination, there was tenderness at CV junction, but there was no palpable deformity. So the clinical diagnosis was post-traumatic supraaxial spine injury with the hemicord syndrome. And this was his preoperative X-ray. There was suspicion of something which is unstable here, but this was his NCCT striker spine. So this boy was already having a congenital CV junction anomaly on which he developed a superadded injury. there was a os odontoidium, and the space available for the cord was really about 9.5 millimeter. So this was his vertical angiography with the right-sided dominant vertebral, and this was his MRI. You can clearly see that there was cord contusion at this level. So we again went ahead with the posterior fixation, C1 and C2 only, and good alignment was achieved in him, and there was the posterior C1 laminectomy was done just to give the cord space over here. Because he was in a bad shape, we didn't try to conserve the C1 posterior arch. So post-operatively, in immediate post-operative, there was slight betterment of the power, but not quite significant one. But there were few complications that he developed a wound dehiscence at the graft site, and which required debridement, then developed pyuria, a abscess in the abdomen which required a pigtail insertion. However, we were lucky that after a few months, the boy sent us a video, and now he's doing fairly fine. So the dilemma by dealing with this case was that whether these morbidities were preventable, and whether there is a role of pre-participation radiological screening in such patients who already have a congenital CV junction anomaly. So while searching the literature, we found that there is no evidence to support plain radiographic screening for asymptomatic AEI. However, still, these patients who are known to have some kind of atlantoaxial dislocation or congenital CV junction anomalies should be discouraged from taking part in high-risk contact sports, and should be supervised. So this again, like Dr. Pruthi showed, a neglected fracture. 6 months ago, the boy had a neck trauma, 16-year-old, no deficits, family refused surgery, went home. But 3 weeks before presentation, then the boy rapidly started to have significant deficits and was brought to us in a wheelchair. Respiration was okay. So you can see clearly that there was significant displacement and significant compression at the CV junction. So this required a significant intraoperative manipulations, and ultimately we were able to reduce it partially and decompress the things. The post-op CT, post-op X-ray was okay, and this is a 2-year follow-up of this boy. The alignment was not perfect, but he behaved well and recovered completely. So this was a case of occipitocervical dissociation. A male who was involved in a high-speed road traffic accident, found unconscious, quadriplegic, GCS 8, and mild pupillary asymmetry because of the diffuse axonal injury. And as Professor Ashim told, the ratios which we see, the Bayesian dental interval, BI, all was increased, including Powers ratio. And the most important objective criteria in these patients in the era of CT would be to see the occipito cervical distance. More than 2.5 millimeter of distance qualifies for a occipito cervical dissociation. The most important point here, as Professor Ashim has also stressed, that the traction must be avoided in these patients, because that would be detrimental and may take life of the patient. Many of these patients do not reach to the hospital, but if they reach in time, so we can treat them. So this was the MRI which showed some hyperintensities in the joint, and we did with the OC1 and C2 fixation, and the patient gradually recovered but was discharged to a rehab status. So then there are a few cases which Professor Deepak has shared with me. So these are all C2 fractures which were managed with the different philosophy. So this is a simple fracture, non-displaced, TAL is intact, so managed with a anterior odontoid screw. But here it is a displaced one, so the likely choice would be to go from the posterior side and C1 C2 fixation again. And Dr. Praputi has also highlighted that we should not extend our fixation beyond C1 and C2, which is the area to be included in the fusion. So this was a old fracture with a pseudoarthrosis, and though some may consider an anterior approach in this patient, but we tried to approach it from posterior side, and pseudoarthrosis could be broken, and everything was done from the posterior side. So this again is an old fracture, neglected one, severe myelopathy and severe compression. So in this case, the ideal approach would have been anterior, and which was done, though the indications of anterior are quite limited, but sometime when it is required, it should be done. So again, good anterior decompression followed by the posterior decompression and posterior instrumentation. And this also patient had an improvement after. This was a small kid, 6-year-old, but and seeing the radiology, you see that there's significant displacement and the cord is kinked over this spike of the vertebra. So in this case, the ideal approach would have been posterior, but as the kid was merasthemic, so an attempt was taken to correct it posteriorly, though a bit of gamble thing, but still it worked, because after correction of the deformity from posterior side, the child also started to recover and started to thrive. So the recovery was quite remarkable after that. So in this patient, anterior approach was avoided because of his poor nutritional status. It was thought that his anterior wound may gape and he may develop complications. So in this patient, again, the posterior approach worked. So take-home messages are that, as my previous speakers have also highlighted, that one should study the detailed imaging for every patient and give importance to each and every part, including facet joint, angiography, anatomy, etc. And fixation has to be decided according to the anatomy, the clinical status of the patient. Radiology alone should not dictate surgery. Most patients do improve neurologically, but we have to go with the loss of motion of some fusion segments. But as Professor Pruthi has highlighted, that it should be to the minimum, whatever is required. So my acknowledgement to Professor Deepak Kumar Singh, Secretary NTSI, for giving us the opportunity as well as helping us in sharing his cases also, and my colleagues, Dr. Bhaskar and Dr. Anil from AIIMS Rishikesh. Thank you.
Thank you, sir, for giving a nice talk, sir.
Dr. Varnan, are you there?
Yeah, I'm here very much. Yeah.
So, sir, now your comments.
Yeah.
I mean, you have gone through, we have gone through, almost everything related to, in short, but everything related to the CVJ trauma.
Yeah.
Sir, what's your take?
Yeah, first and foremost, congratulations to NTSI for doing this webinar and conducting it very well. I also like to congratulate the speakers who have touched almost everything, starting from the anatomy, the biomechanics, and the different ranges of movement, as well as the different types of fractures, which you have explained. Okay. And I think all the speakers have also explained the types of fractures as well as the treatment strategies. But in my experience, what I've seen is that one surgery which you plan for a certain type of fracture does not suffice for the other patient, because three things what one has to look is the fracture is, this is a traumatic fracture, number one. It is a post-trauma. It is not like a normal CV junction anomaly which we operate. So there are three aspects which we have to look. One is the angulation. What happens to the amount of dislocation which takes place? The displacement you have to evaluate not only anterior posteriorly, you have to evaluate it laterally also, horizontally. And the third is the degree of cord compression, which is the culprit for the neurological deficit. It's an acute neurological deficit which happens, okay? Many times there is also respiratory problems which occur, and these patients have to be taken on ventilator before you operate on them. So all these things have to be taken into consideration. And the important thing is that you have to plan. Now, everything cannot be done posteriorly. Most of the speakers, they have discussed only fractures involving the C2. Okay, it can be C2 body has been discussed, then the hangman's fracture has been discussed. So they have not taken consideration of what happens when C1 is fractured, when the two lateral masses are fractured. So these can be associated injuries. Very many times you'll have the C1 fractured into 3-4 pieces, or the C2 fractured into 2-3 pieces. So in that type of injuries, your strategies have to change. You can't have fixed strategies that I will only go from front and fix. Many times I have gone anteriorly, especially for a hangman's fracture. The procedure now which I do is I expose both the joints and fix the joints by either the Goel plate or I use the Patkar plate. So I've shown it in my presentation also, where you can fix anteriorly. And that is one of our good fixations, especially for a child. Because child, when you have a hangman's fracture, When you're putting the screw, first of all, you don't get the diameter or the size of that diameter of the screw. And it has to be a reduction screw, because otherwise the body starts moving in front as you tighten it. And you find difficulty in fixing it because you don't get a purchase. When both sides of the pars interarticularis are fractured, the fragment is unstable. It keeps moving as you put the screw. So that is the problem. Doing the tap itself is difficult. So in these type of fractures, I found it more comfortable to go anteriorly, and you can fix the joint anteriorly, okay, either through the high submandibular approach, or you can do it even transoral if required, which we have done. So you got to keep all types of options in your basket before you handle this. The 3D CT scan is very, very important. You got to see the 3D CT scan to see the amount of translation which happens here. And also, somebody said skeletal traction is a big no-no, but it is required during surgery. Now, we do not put skeletal traction initially unless if it is, an old fracture which has come. But otherwise, intra-op, you got to stabilize this by putting skeletal traction. But we do not need distraction, too much of distraction. It is just to fix the segment. So this is what we still do. Thank you.
Sure, sir. Thank you, sir. Dr. Nupur, there was a question from the audience from Dr. Raj about the anterior versus posterior approach in hangman fracture salon.
Yes, sir.
So what's your take on that? What you will, suggest to the newer, younger people who are watching this?
So there are two approaches. Classically, there was only one approach, but now there are two approaches. The one is to take out the disc and diffuse the body with the C2 body with the C2-3. Now, as I think all of us have done many anterior cervicals in this group, we know how difficult it's very difficult to reach the C2-3, and you need to have a good patient with a good neck if you want to do it very easily. So that is why it is not surprising that posterior approach is very popular. The other approach, Dr. Vernon just told us to go to the joints and do that. Now, the kind of fractures, I think the first case which Dr. Rajneesh, I think, showed us was there was a chip fracture also in the front. So when you remove that chip fracture, again, getting a screw in C2 might be difficult, in my opinion. However, that if it is a significant fragment, that might be difficult. So see, compression from anterior, if you correct the angulation from posterior, I think it's quite okay. So I would prefer posterior because I'm more happy with the posterior approach. Anterior approach, I'm not very comfortable. That is my honest answer. But yes, if you can do that, if you get that disc out anteriorly, if you have good instrumentation, like Dr. Vernon also stressed a very important point, and I tell you again, you need to have good instrumentation. You see, if you need to be comfortable with also all kinds of instrumentation, not only just approaches. See, as he told, I don't think there is a good anterior cervical system which gives you a good plate for that small area between C2 and C3. Whereas the Goel plate or the Parker's plate is a very good alternative for the joint fusion. And I have seen in my own institute those kind of, and ACD have done C2-3 failing and then implants coming out. But I think in my experience, posterior is safer. I think so.
Deepak Jha, sir.
So there is
What's
one.
your own take? What's your take?
No, first of all, one chat box, there is one message whether it will be available on YouTube, because the presentations were excellent. So residents or young neurosurgeons may like to get it later. Possible?
No,
yes, sir. Sure, sir. We'll put it on YouTube, sir. We'll put it on NTSI YouTube channel. That all webinar is being recorded, and we'll put it on YouTube, sir.
It will be available.
Okay, thank you. So that will be very good help for the young neurosurgeons. And we in India have seen all types of CV junction, excellent, and like Dr. Goel, Dr. Patkar, and all of us have done a lot of CV junction surgeries. So few things which for the residents or young neurosurgeons: prevention of vertebral artery injury, prevention of whether C2 nerve root can be preserved, and role of X-ray and thereof CT scan or MRI. So these are the few things that the speakers can put some light on if they They can. So role of X-ray in current era, is there any role of X-ray if CT-MRI is available?
Rashim sir, are you there, sir?
Dr. Rasim, Dr.
Dr.
Nupur,
Rashim sir?
I am
or Dr.
available.
Adnis, anyone?
Sir, so there is a question from Dr. Deepak Jha, sir.
Mhm.
What is the role of X-ray in the current era? And sir, I also want to ask for the newer people who are saying this. So what type of investigations you order in a patient when he come to you as a suspected CVJ trauma? So,
So
you
like
know, this question is being asked repeatedly to many of the, you know, examinees that what are the
Definitely.
investigations that you will proceed with. So I
And-
just want an answer from, you know, the panelists that what sort of answer, because in the today era of CT scan, X-ray is obviously not being used that much. So
And
what's
one addition, whether you use any type of immobilization after surgery, if yes, which type of immobilization and why? So speakers can put some light on these few queries which frequently are asked in the examination to the.
So, Dr. Rashim, I think I think I will start the discussion. I think
Okay, go ahead.
very important question, and I'm honestly a big fan of X-rays. See, a lot of times there is instability. There is instability, and especially if there is only ligamentous instability. Please understand this. Only ligamentous instability. And Dr. Rashim also highlighted this point. Your all bones will be normal. If you do an MRI or a CT scan in lying down position, you will not see anything. The only way this disease is going to be caught is by doing a dynamic X-ray. So I can also show you many patients in which the MRI was normal, everything was normal. The only way we picked up the problem was even in 2025, a old classical dynamic X-ray of the patient. Number two, my point is, intra-op, you still have only X-rays available to you. Intra-op, I mean,
Yes,
many centers.
that is
I
very
don't know
important point.
how many of us have OARM and intra-op
No,
OARM,
no.
and even if we
See,
have, it is cumbersome to take it in and take it out. So I think the only thing
so-
available to you in intra-op is X-rays. So if you don't know how to read those X-rays, and if those interested, I have a very good article on how to use X-rays and what to see in X-rays intra-op. If those interested can check that article. I think it's very important. You should know the X-ray in and out, even in 2025.
So therefore, if you have a pre-operative X-ray, you can compare it in the
Exactly.
OT with CM. So
Yes,
that is
yes.
very helpful. Okay.
Absolutely.
So how do you preserve C2 nerve root, or you sacrifice it because you have to work at C1 C2 joint
I think
on both the sides?
Dr. Rashim has come.
yeah,
Okay.
sure. Sorry. Yeah, shall I answer your question,
Yeah,
Doctor?
please.
Yeah.
Please go ahead.
So we try to take the nerve down, but in case like it is difficult, in case the exposure is more important than preserving the nerve. So it is a
No.
principle.
No. Traumatic CV junction, C1, C2, not congenital anomalous.
Yeah, but still, if it is like if the lateral mass entry point is not visible because of the nerve, I don't hesitate sacrificing the nerve. Yes, I try to save it, going superior, putting a traction on the nerve. But still, if it is bulky or if it is not, like it is hindering my the vision entry point, then I don't hesitate in sacrificing the nerve. Yeah, I try to save it.
Dr. Rajneesh, you want to add anything? Rajneesh? I think Rajneesh is not there.
Yeah, Rajneesh has left, sir.
Dr. Adesh, you want to add any point?
Yeah, sir, what I learned, especially from Dr. Nupur's studies, which he has been presenting for so long now, using the vertebral distractor, if you can somehow place the distractor at the C1 arch, C2 arch more towards the lateral side and the occiput and try to open it up, one can create enough space so that the C2 ganglion can be preserved and the screws can still be placed. Yes, it does create a problem if you want to put in a spacer, but if you just want to put in small bony chips between the C1, C2 joints, then this gentle distraction and then working around the C2 ganglion, the ganglion is mostly saved, sir.
So, sir, what we have done, we have published a paper in Asian Spine Journal few years back, in which we have described the technique of C2 superior facet drilling. So, in case of going directly into the joint, to reach to the joint without touching the vertebral artery or without touching the C2 nerve root ganglion, we are drilling a part of the C2 superior facet that is coming in front of the joint. So we'll drill that C2 superior facet off, and then we gain a direct entry way below from what is the routine entry point into the C1 lateral masses. That is the one technique that we have described that we call the C2 superior fasciotomy. And that technique actually we have published, especially in congenital CVJ. It is very helpful where the C2 is very high riding. But for trauma cases where the joint is absolutely parallel, obviously this technique is also very challenging. So this is one thing that we can adopt into our practice for preserving the C2 nerve ganglion and even most difficult V artery anatomy. So that is one thing that we can, that I have learned from my practice.
And the last was vertebral artery, because due to vertebral artery, fear of vertebral artery injury, young neurosurgeons are afraid to do CV junction surgeries. So what are the tips for the young neurosurgeons from the speakers and anyone, senior
Sir,
people?
sir, if
please go ahead. Please go ahead.
So I think when we started
and
doing CV junction,
what is to be done if it occurs accidentally?
Yeah, coming to the first part of the question, I think obviously one has to learn the proper technique of dissection, but the most important thing which we have inculcated in our practice is now that thin slice CT scans are available everywhere. You get a CD, everybody has a laptop, you have DICOM images, and there are ample amount of softwares available. So a thorough study of 3D VR reconstruction, that gives us an idea of the 3D anatomy of where we can encounter the vertebral artery, where to expect the vertebral artery curving laterally after coming out from the C2, even where when you are exposing the C2 lamina and moving more laterally, where you anticipate the foramen will be and the vertebral artery would be coming out. Similarly, the lateral course, and if it is having an anomalous. The most important investigation which has helped us in preventing vertebral artery injury in our practice has been the regular and thorough study of VR images of the CT angiogram, which is done in all these cases. That's my take, sir, on that.
Professor Varnan, what's your take on intraoperative vertebral artery injury, sir?
No, see, first, before you have an injury, you have to do a 3D CT with an angio, okay, and see which is dominant. That is very, very important. Which side is dominant? If you have, one side, dominant side injury, then you're going to have problems. So that is very important. Second thing is the vertebral artery injury can take place in two ways. One is you have to know whether it is a high riding, okay, or whether it's a normally placed vertebral artery. So in a high riding, you have to be ready for it, and you have to drill and keep the vertebral arteries aside. So it's not difficult to mobilize the vertebral artery and keep it out. I've shown in my videos also that you can do it beautifully. And the problem is when you injure the vertebral artery, when you're putting the screw. So that injury cannot, one thing is once it happens, you can't do anything. You have to continue putting the screw. You can't stop putting the screw. You have to put the screw, take the patient for a DSA immediately. Okay, there's no need to stop your procedure, because if it's a non-dominant vertebral artery, you can get away with it. Understood? So there's nothing that you should be afraid of the vertebral artery. It is more, you should be more afraid of the vertebral plexus, which is around the artery. So that bleeding is more than the vertebral artery itself, because that is something which can test your patients, the vertebral venous plexus. So the technique is for vertebral venous plexus also, when you see the bleeding and the bleeding is not stopping, then you can use flowable gelatin, which is very good, or come down on the traction. First thing is to come down on the traction. If you have given too much traction, more than 7 kilos traction, then the venous bleeding will not stop. So vertebral artery is not a big deal if you have planned for your surgery by doing the vertebral, this angiogram. Sometimes it can come right across the joint, C1, C2. So that's the place where you will have to mobilize it. Sometimes it is very close to the C2, ganglion and the nerve root. So it is the studying of the scan which is very, very important before you plan your surgery.
Thank you, sir.
And to add to it, can I speak? Yeah,
Yes, yes,
and
please, please.
to make the thing simple, like as we have done, like we used to make models for that. So model gives a very lucid information about the course of the artery, course of the anomalous artery. So you need not to scratch your head like as Dr.
Yeah,
Adesh has
only
told.
thing is, Rashim, the acute trauma, the 3D models, it becomes a problem because you have to operate early. So 3D models take a week for them to be made. So in acute trauma, we do not, where we have to operate within 24 hours, we use the 3D CT with the angio.
Yes,
So if it is a routine case like a normal CV junction, we always do a 3D model.
Okay, Dr. Nupur.
Sir, I think just to add, excellent points have already been told. For the younger our colleagues, I just want to add a couple of points. One is never assume that the vertebral artery is in normal position, especially because today we are dealing with trauma cases. See, in congenital cases, always you will be doing this angiograms. But even in trauma, please never assume that vertebral artery is in normal position. Now, even if vertebral artery is in normal position, remember there are two areas rather, which are very safe. One is the medial border of the C2 pars. If you stay on the medial border of the C2 pars, you are usually away from the vertebral artery. So stay away from the lateral border of C2 pars where all the vertebral artery will be there. Number two, stay away from the superior surface of C1 posterior arch. So stay on the inferior side of C1 posterior arch, and make sure you don't venture out much lateral to the facet joint, because again vertebral artery is lateral to the facet joint. So when you're doing intra-joint work, please stay inside the joint or maybe a little medial rather than lateral, because these are a few tips. And I would also like to have Dr. Jha's opinion on this.
Actually, the same thing, slightly different, slightly additional point. I identified this, I tried to identify on VRT images the segment of bone between exit of vertebral artery from C2 pars and medial part of lamina. So medial part
Yes,
of
sir.
lamina to the medial border of the vertebral artery exit from the C2 pars. That bone block I identify, and I always remain center for all the types of instrumentation, whether pars, whether orthopedical, because that is the block of the bone which is medial to the vertebral artery. So I just, and like other speakers in the past have shown that if during putting the screw and you take out your whatever tap or all or anything, you see that there is arterial blood of gus of arterial blood, you just put in the screw, it stops. How, I don't know, but we have faced it. We have put in the screw, it stops. Got CT angio, it remains normal. So it is how it was found, and it is reported in the literature also. If it is on the surface, it is ruptured or torn or due to some reason,
While
cautery or
dissection.
blade, while dissection. It can be repaired very easily, usually, because it takes 1 or 2 stitches only. Muscle, you can find muscle there, crust muscle over it, stops the bleeding always for some time till you get the proximal and distal end. So that was shown by many surgeons at our center also. Because CV junction, I think Indians are the masters. Nobody else is no better than us. So we all of us have faced such problems. And for C2 nerve, C2 ganglion nerve preservation, what I find, if we mobilize the soft tissue, there is a plane. The C2 nerve root is between the plane of the of triangle, suboccipital triangle, that and lateral, because all the muscles are attached either to the spine or C1 tubercle in the midline, and lateral foramen transversum, which is the transverse process actually of C2 and C1. So there is always a plane, potential plane. If you subperiosteally dissect the muscle from the midline, C2 spine and C1 tubercle, posterior tubercle, all the muscles can be separated, mobilized laterally. Do it properly to the more lateral side. The length of the C2 nerve that you get is more, and then you can mobilize it. The lateral mobilization is less, the muscle is stretched and taut. If you mobilize between the C1, C2 in that plane, superiorly lateral, till the lateral tip of the C1 foramen transverse cerium or C2 foramen transverse cerium. That is transverse process actually. The tip of the transverse process, till that, if we can mobilize it, the length of the C2 nerve is quite big. And it can be retractable up or down. So this is what I have found. So, and what do you use collars? All of you, whether you use collar after surgery for post-operative period?
Yes, sir. It's routine in my practice.
So anyone who differs? And unilateral fixation. Dr. Nupur was telling.
Yeah.
So we have faced, due to some technical reasons or due to bony anatomy, we also have done few cases.
Yes, sir. Everyone actually who is into CVJ surgery. I mean, there are instances there
we have to do only unilateral
only
fixation.
one
And Nupur's finding is perfect that
it has
it
happened.
Worked.
Sir. Yes.
It worked.
It has happened.
So I think we can think about.
But I think there are certain cases in which it might not work.
Yeah, definitely.
I have a couple of cases in which I lost the reduction, but they fused in malposition, but patient is doing well. I could not hold on to the reduction that we achieved, but yes.
So in cases where, we have to put only one-sided C1, C2 fixation, especially in congenital cases, what we used to do because of very difficult VA anatomy on the other side, what we call a 3-point fixation or hybrid fixation. In that cases, we do C1, C2 on one side, and then C1, C2 on one side actually completely reduces, the dislocation. And we use an occipital plate and bilateral cross translaminal C2 screws, and we create a sort of hybrid fixation in that cases, just to supplement the C1, C2 fixation on one side. So that also we have adopted, and I think many of us who are into CVJ surgery, they have developed their own techniques, their own escape out mechanisms to, go through all their difficult case scenarios. And
so,
this happens.
And how do you tackle the very small child, 1 year, 2 year, or 3 year child? Their C1 arch is not complete. Lateral masses are very small. So how do you get those implants?
Sir,
Dr.
I have
Vernon
operated like a 6-month-old child.
Uh-huh.
And we have our own, very small type of screws, 2.5 mm, or you can, for radial fixation, the orthopedicians use, very small screws.
We have pediatric sets also available now.
Yes, pediatric available, sir. But what I used to do, I used to do, the radial arm for radial fixation, radial fracture fixation. The orthopedicians have very small screw and plate subsets. So, and that are locking and dynamic plates also.
And yeah, the Goel plate is good. The Goel plate system is good for children.
Goel plate system is also very good.
Goel screws are 2.8 mm screws.
Yeah.
So I mean,
that's the advantage of Goel plate. You can use it in adults as well as children.
Yes, sir. Yes, sir.
So the availability is the problem, because
no, you get it freely. Yeah.
At Rajasthan,
it's available freely.
At type B cities, it becomes difficult for those vendors or suppliers.
Not at all.
Sir, you can't believe, but in one case, in a child, it's a very, highly mobile C1, C2 joint, I used, that surgery type of plate screws also. And
Goel was there for some time. He was there. I saw his photograph. Means his video was on. I don't know whether he's still there. Yeah. But for a child,
Goel has actually said that he'll join. I don't know whether he is there or not.
No, Dr. Goel is not there.
Yeah, he joined initially.
No, sir has left, sir.
So I think it's very, insightful session, and every word, every sentence the speakers spoke and, the panelists have said about the CVJ injuries is actually, something to re-listen for many times. You have to, listen this talk again to get all the information and, just to make a picture in your mind that what additional you can add up to into practice. So I think I will conclude the session, and I like to thank you, Dr.
Just last point, Dr. Deepak. So,
yes, sir.
Dr. Goel is not there, but I have seen him operating CV junction C1, C2. So what he does, while working on the joint, he puts whatever visible posterior inferior corner of the C1 lateral mass. because that is visible while we start working on the joint, C1, C2 joint.
Yes.
So very small part of posterior inferior part of the C1 lateral mass is visible. He puts a screw there only. So that's how he doesn't need to handle any, he doesn't handle at all the C2 nerve. So his C1 screw is at that point, posterior inferior corner of the C1 lateral mass. Because recently I had seen him operating at Bombay. So I found that very good. And otherwise C1 at the same point, subfacetal, subarticular screw that Dr. Deepak has mentioned.
Definitely his system has some advantages, but I mean, there are some disadvantages also.
Yeah.
We have seen,
Okay.
through
Okay.
past years that both systems, whether screw system and rod system or the plate system or coil plate system, they have their own advantages, they have their own disadvantages.
Not the system, just a screw. Where
So
to
sir,
put in?
screw is actually the screw. His screw has very sharp tip, and it
No,
goes
we
through
can
the
put
plate.
in. We can put our whatever screws we are
And
inserting.
I think he is using his screw is bit
very
smaller,
small,
smaller than
much thinner.
what the
Yeah.
average pedicle, screw and rod system available is.
Okay,
So I think
Dr.
it's
Deepak, you
two-pointed
can
system.
conclude. Okay.
So I'd like to thank you, Professor Rashim, Professor Nupur, and Professor Rajneesh for wonderful talk and lot of insightful inputs from our panelists. Dr. Varnan Velu is obviously the champion of CVJ surgery. He has shown everything to us. Dr. Deepak Jha has published so many newer things. I sir, cherish all your articles. I go through them, and your innovative ideas, always keep on adding something. And Dr. Adesh, your insight and your experience has made this session marvelous.
Thank you,
And
sir.
I
Thank
would
you so
like to
much.
thank all the listeners also for joining this. This is only the second webinar of the NTSI that we have started, and once
great.
I've seen that the number of people listening to this is actually up to 45 to 50 is what ranging, and actually it's quite a lot if you consider the number of webinars going on right now. It's quite a lot actually. So I would like to thank you all once again, and thank you so much for joining.
Thank you.
Thank you, sir. Thank you so
Thank
much.
you, sir.
Well done.
Thank you.
Well done, NTSI.
Thank you.
Thank you, sir.